Hi everyone, I'm Dr. Faisel Syed,
And I'm Dr. Dan McCarter.
and you're listening to Faisel Friends, where we believe access to primary care is a right, not a privilege.
Today, we're talking to Dr. Ishani Ganguli from Harvard Medical School and Brigham and Women's Hospital about driving change through research. Let's dive right in.
Hi there, Dr. Dan. How are you doing?
I'm doing well, Faisel. How are you today?
I'm very excited. Really looking forward to having this conversation with Dr. Ishani Ganguli. Dr. Ganguli, welcome. Thank you so much for taking the time out to join us today.
Thanks for having me.
You know, one of the things that we love to start off with our doctors is, what was it that drew you to medicine? Like, what was it in your childhood and your early? What was it that was that attracted you to pursuing studying medicine?
Yeah, it's a great question. I think unlike a lot of my colleagues that I see, I didn't have doctors in the family. And I think in some ways that was what drew me, as a child of Indian immigrants, there was always this notion that, well, we need a doctor in the family. And so maybe you'll be the one. I grew up having a really strong interest in science, but also people. And that combination was really, part of what brought me there. I will say that in college, I was pre-med, I was studying biochemistry, and I also really got interested in journalism. So I was writing for my school paper and then increasingly, for the Boston Globe and other settings. I saw a lot of parallels between journalism and medicine as well. And so, the idea of distilling complex ideas to help the person in front of you, whether that's, writing an article about something and trying to make sense of it for the lay public, or talking to the patient sitting in front of you. So, that was a big driver for me. And in fact, I did medical journalism alongside medicine during my training, and still do a little bit of that today.
You never really hear that. I remember the first time I heard you speak live in person was just this past year. It was earlier this year, and I was so impressed with your background with journalism and with storytelling and your passion with telling that story. You know, these days, especially now with all the information that comes in so many different places, it's one of the biggest tragedies of our time is that we've got access to all this information, and there's so much misinformation out there.
Mm-hmm.
So, how do you feel about helping people come to conclusions, especially with medicine, when there's just so much misinformation out there? Like, what are some effective ways that we can start getting real information out that actually makes sense to the common person?
Yeah, it is such a challenge. I agree. I think that misinformation and sort of dedicated campaigns to spread misinformation are a real threat to the health of our society right now. I think what doctors can do. I think there's two models that I've seen work well. Right, one is on social media and other outlets, just getting good information out there, almost like a numbers game, to have the good outweigh the misinformation, and have consistent sources of that information that people can trust. The other idea goes back to something we all think about a lot in primary care, which is just using those trusting relationships, or leveraging trusting relationships between patients and their doctor or their clinician, right? So, an individual may hear lots of different pieces of information on the internet, but then they can go see their doctor and feel assured that they're getting good information about how to take care of a medical problem or a public health need.
Yeah, we see that so much in the underserved populations in general. My background is community health. We saw it in the community health centers very regularly, where the patients only used the healthcare delivery system when they felt the need, like they had to present with some complaint. But for a regular checkup or something that a physical or wellness visit, that was low on the priority because of several reasons. And so we actually had to spend a lot of time with building trust, with even just one or two visits per year. Sometimes that may be your only opportunity, that one interaction, that one sore throat may be your only interaction with the patient for that year, not only you as a doctor, but for everyone in the team. So building trust in underserved populations is quite challenging, especially when the frequency of visits is so much lower with outpatient primary care than you do. We'll see them many more times. They'll be seen in the emergency room or in other places.
Yeah, so much. Yeah, I agree. And there's so much to unpack there. I think there's this, We know that we're seeing a decline in primary care visits, and some of that is being replaced by patients getting care in other ways from their primary care offices, but also just going in less often. So there are fewer opportunities to build that trust, but I couldn't agree more that if you have your person, it doesn't matter if you're coming in. In other words, if you have your doc or your clinician, right, who you consider yours, your personal person, you might be coming in for knee pain, but that person knows you, knows what you need, screens you for depression, and sees that you look a little different than usual. You're not acting like yourself, and is able to intervene in that moment. So there's so many benefits, I agree, of having that relationship. And we know that so many people don't have access to those relationships, and that's a real problem.
Something that we're really impressed with what you've written about, especially with Medicare patients. Some of the patients that are the most have the most difficulty with getting to see the doctor are the ones who need to see them the most. And then the surprise. I mean, we all know in healthcare delivery. I mean, what a big shock, the population. That I'd like for you to talk a little bit about the population who needs to see the doctors the most, but they're the ones who actually have the least access.
Yeah, I think there's a couple different ways of parsing that, right? One is we know that there are these disparities in care by race and ethnicity. There's disparities based on income, where geographically health facilities are located. They're moving out of low income areas, for example. And another aspect of this that we studied recently is this idea that many patients have trouble getting to the doctor's office. And we did this analysis of a nationally representative Medicare survey. So looking at patients who are in traditional Medicare and Medicare Advantage, and 17% of them reported difficulty getting to the doctor's office. So it really, makes you think a lot about, the importance of access and finding ways of supporting that care, but also on the clinician side, being more creative in how we deliver that care. Not everything has to be done in the office, right? And so we've seen this real uptick in use of telemedicine, a surge early in the pandemic that has diminished but still exists. There's the importance of home visits. There's the importance of using the team, which I know you all think a lot about as well.
Yeah, we had to make some major changes, especially during the pandemic forced us, because our patients live in the underserved neighborhoods, the typical neighborhoods where you see only the federally qualified health centers.
But I mean, so we were just talking about the gender bias in healthcare, and I think part of what led us to our initial discussion is we were talking about um, the struggles that of gender bias in academic medicine and professional medicine in general, and we know that many of the primary care providers, if not most now, are female. And part of I think I had told you, I was talking to one of our younger doctors who had asked me how to deal with an issue as a female physician. And I told her, well, my first thought was don't listen to old white guys. So let's go find some women to ask the question. But we've got just you're a prolific researcher. What's your advice to the young women who are thinking about this now?
Thank you so much. I guess there's several ways to get at this. I think just going back to the themes that Faisal was raising earlier, there we have some interesting results on gender differences in how we practice primary care, which have implications more broadly beyond gender, right? So we did an analysis in 2020 using national electronic health record data, which included detailed information on how much time patients and doctors were spending together in visits. And what we found was that women PCPs conducted fewer visits with fewer patients over a year, but spent more time in those visits with than male PCPs, either both per visit and over the course of the year. So they were getting paid based on the visit. So they had 11% less revenue over the year, but they were actually spending more face-to-face time. And that doesn't even include the non-face-to-face time that we know from other studies women spend, either answering the higher share of patient portal messages that they receive compared to men, or doing other work, taking care of patients. And so what that really signifies to me is that our payment models have been very much focused on volume, right? We know this, and we know all the challenges of that in primary care. And it turns out that women seem to be, sort of not maybe not succumbing to that pressure as much, for better or worse, whether that's because there are higher expectations of women or different expectations of women that patients expect them to spend more time, or women have that tendency on average compared to male doctors. But whatever it is, it's something that, time is valuable for all PCPs, and it turns out that women seem to be providing more of that time at personal cost. And what I take from that is that we need to fundamentally change how we pay for primary care, because that's not a sustainable model for anybody. Male PCPs want to spend more time on average, but don't get to, and female PCPs do and pay a price.